Thank you. And yeah, look, apologies, you guys have already heard probably enough of me this morning. So it wasn't the intention when, in terms of how they've scheduled this. And I'm presenting this, so I just, there we go. This is work done, Michael Impolito, who's a psychiatry trainee in Canberra and who's done this work with us. So really this is his work, but he wasn't able to attend today. So yeah, to acknowledge the Gadigal people and the many people whose data that we're using. So look, this is really just a slightly, I think you've already heard the punchline of this story now in terms of the figures. So perhaps it's just a chance to expand a little bit. And very interested in your thoughts about the kind of, well, what might be the options for dealing with this. So I'll try and be quick and give us some time for discussion. Yeah, cervical cancer is, these days a largely preventable cancer. It's the fourth most common cancer in Australian women. Causes nearly 2 deaths per 100,000. And lean to the microphone. Okay, I will do. Thanks. People would be aware there's a national cervical cancer screening program, free screening for women aged 25 to 74. And despite the good evidence that it works, only about half of the eligible population participates in screening, and that's a pretty common figure. It's similar in the bowel cancer screening program. It's only a challenge for the cancer services worry about. The cancer screening program has undergone quite a lot of changes. So it was introduced in 1991. The big revolution really in the understanding of cervical cancer was the recognition of its viral origins and the introduction of HPV vaccine, mainly through schools in 2007. And in 2017, the system changed from 2-year PAP tests to 5-yearly HPV testing. And so our data that this is from is only up to 2017. Having said we need recent data, this has been the most recent data available to us at this point. The other change that we'll come back to is that last year, an additional option for self-collection was added to the national program. There is evidence from some overseas studies that suggest lower screening rates. Steve Keisley Cheesley and Keisley did a recent study where they looked at using the PBS data as a measure of serious mental illness, so people who'd received more than 2 antipsychotic scripts, and found about a 17% gap in screening rates. So the reason we wanted to do some more work was partly to add to the evidence and for some statistical reasons, but particularly exactly the issues that we just heard me talk about, which is really trying to develop the local data that can help support change. So I won't go through the program because you've heard about that. So this is what we did. So in New South Wales, there was about 2.2 million women in that age range for the cervical cancer screening over that period. So we looked at 2 years up to the middle of 2017. And then we split by mental health service user status. So, and in this data, mental health service users are defined as people who've had contact with a public or a private hospital for mental health care, or our public community mental health services. So we don't have private community care, GPs or private specialists in our data set. So this is the figure that we talked about earlier, that only 40% of mental health service users have been screened, which is about a quarter less than it should be, based on not just the age, but disadvantage and rural location. And that's that gap, 16,000 people. So it's not just a statistically significant gap, but a really important number of people who could be screened. This is just to show that, because often, and one of the barriers I think is sometimes when we present data, say for example, Russell asked me a question earlier about chief executives. Sometimes when we present data, and then sometimes people kind of tend to dismiss and go, okay, but that's just because people are more disadvantaged or live in different parts of the state. And pretty much over and over, whenever we look at the data, adjusting for those things, either it makes no difference or it actually amplifies the difference. So it's effectively none of the differences that we see can be just explained away by disadvantage. And then this is the age distribution. And that really, and our colleagues at Cancer Institute have really been scratching their head. This to them was the most surprising finding, that how different it was in age. So in women under 34, there was, the rates were about 90% to 95% of the population rate, and then it drops off with age, and that really steep drop off in older women. And I guess, yeah, we are trying to plan what the next in the next study and with the updated data, how we might look at that in a bit more detail. And really, there's those two possible explanations. It could be, what you could call a cohort effect, and it's a different age group, and that those women who are 34, or under in this age group have been through the HPV vaccination program at school, and there's an awareness and perhaps a kind of a different attitude. The other issue might be just that we know that there's a mix, it's a different group of people in terms of mental health services when they're seeing younger people. Often that's because of anxiety, depression, brief emergency contacts, and whereas older people in contact with our services might be more likely to have an enduring illness, and so it might be just that's about a different group of people with different needs that are being seen. But I do think this is, it's worth thinking about in terms of the different implications, both for the older person services, but even for the younger person services. I know in early psychosis services, working in a community early psychosis service, we would definitely provide advice about contraception and safe sex, but it never occurred to me to ask people about, have you had your HPV vaccination? You might have missed school that day or week when that was happening, so, and I think, we could be asking those kind of questions. It's not too late to get those vaccinations, even at a slightly older age. So, this issue about the variation across the state, and there is definitely lower rates in Western and Southwest Sydney, in screening, and that probably speaks to some of the cultural issues as well, perhaps in some of this kind of screening. But yeah, there really are gaps everywhere. There are, and in looking at these prevention things, I guess we need to understand what's the combination. There's going to be things that affect mental health service users that are the same things that affect everybody else in that population in terms of the accessibility of the services, or the cost, or how it's organised. Then there'll be others that are different and unique to each LHD. And so, there are some real differences here, and particularly for cervical screening, the correlation between the rate in the mental health service users and the rate in the population is much lower. So there's probably more local factors affecting what's happening for mental health service users, which suggests there's things that could be changed and improved. So really, I think, the important question is this, which is how can we work to support better screening participation? Certainly, as I said, Cancer Institute have been really engaged and supportive of this work, and there's clearly a need to work in partnership. Unlike breast screening, where it's done through a centrally run program, cervical cancer screening is really largely an issue that's done in primary care and general practitioners. So engaging with PHNs and GPs is obviously critical. Understanding barriers. There's been not a lot of work to really understand the barriers. Kathy Owen in Canberra did a study about 20 years ago of interviewing people and understanding the barriers. And mostly the barriers are not, they're addressable barriers. They're health system barriers, cost, accessibility, stigma, having fragmented care. People would much rather have screening as part of seeing a GP that they already know and trust, those kind of issues. So, but there's definitely more work needed to understand the barriers. And there's going to be a range of other issues for particular groups. Jen from our team and I have been trying to look to find, well, what's the information that's out there? There are some good support materials about cancer screening aimed at women with disability, but they're very much focused on physical disability. There's not a lot of good materials, and that's probably scope to develop some work to support efforts. And particularly for this area, perhaps the issues of what's both culturally safe and trauma sensitive. And I'm very interested in people's thoughts. It's and not wanting to kind of make any kind of sweeping assumptions about this, but that introduction of self-assessment last year as an option, so people can to take the swab and screen for themselves and post that in. That's a different approach. For some people, that might be more acceptable. For others, that might not be acceptable at all. So, be interested in people's thoughts about whether that's something that's got more of a role to play, perhaps, in some groups. So, so look, there's a couple of limitations there. the biggest limitation, I think, in this data for us is it's only data to 2017 under the old PAP test regime. And we in the next linkage, which is due in the next 6 weeks, we'll have updated data. I guess the other thing we're keen to look at is overall, how's the COVID pandemic affected? And we know that in general, screening and preventative care has really been bumped and affected across the state for the whole population. But I suspect that the impact of these last few years is going to be even worse than the gaps that are there for our ambulance service users. So yeah, I'll stop there. Take any questions? Well, yeah, any thoughts on what we could do better? Yeah.
So maybe a starting point is open up that discussion and
thanks, Brian. As a formal consultant nurse working with South East Sydney,
Yep.
Really interested in the discussion. I did a study a few years ago around why it was in a Cervical facility, so
Yep.
the facility, so
Yes.
we to help that. And I mean, I think the first topic you noticed was that the women on the scene presented so much more frequently with abdomen.
Right.
So I guess that maybe we have the younger representation of mental health service users and references to the sexual assault services, the violence, the child, particularly. So now that we have changed, the violence and vaccines, and we found this involved, we found it's very more times more frequently the policy and vaccines.
Right.
So I think putting a really self-pay in those different services.
Yep.
Maybe the big difference because so they can still always appreciate to
Yes. Yes. Yeah.
Yeah, sexual assault, violence,
Yeah.
life circumstances. It really is sort of like to why we explain the two. That's very, very
Right.
it's a really interesting.
Thank you. Yeah. Yeah. So thank you. And look, it'd be great to get more like that kind of clinical experience that you've had documented and out there too, because there's not, when you look for sort of what can we do, there's not a lot, that kind of really documents that. So yeah. Yeah. Thanks.
Is there one more question? Please.
Question with the capacity. Is that
Yes.
pilot or is this going to be going towards someone who can find people working people, especially for like 3 years ago, there was a program that is now house setting and thing.
Look, my understanding, and please correct me if I'm wrong, because I'm not 100% expert on it, but I think it's now a formal and ongoing part of the program. I don't think it's just a pilot. I'm looking to you, Jen. Yep.
I think
Right, interesting. Yeah. But look, it probably goes to the point that, if the lack of information. So definitely, there could be a need there to make sure we've got good information that answers some of those questions, like what does it involve, and is this going to be around forever, and also just the non-material aspects of how to do it. Yeah. Okay, thank you. Thank you.
Another.